So I wanted to just give a little bit of background information on cannabis use. So I've borrowed Etty Matalon's presentation slides on cannabis use. So just a few FYI facts. Cannabis is still the most widely used illicit drug in Australia. Of the illicit substances, cannabis is the most widely used in the world. 160 million people, around about, worldwide used cannabis in 2005. And this outweighs the number of users of all other illicit substances put together. So it's really, it's a huge phenomenon. 35.4% of Australians, so around 8 million, have tried cannabis at least once. 10.3% have used cannabis in the last year, so that's 2.3 million Australians. And 4% have used cannabis in the last week. 1.6% of the population meet the criteria for cannabis dependence, and I guess that's probably, more interesting in a way, that's still a significant number of the population. 2.5% would fit the criteria for misuse or abuse, and here's the really interesting thing to me, 68.8%, so almost 70% of recent users had mixed tobacco with their cannabis. And in my experience, those other people must have been New Zealanders, because really, you don't really get to see Australians that don't mull up with tobacco. That's certainly what we hear anecdotally, and that seems to match out. So the patterns of use from the 2010 National Drug Household Survey from the AIHW, 8 million Australians had ever tried cannabis. Of the 2.3 million Australians who used cannabis last year, 1 in 6 used it every day. An additional 1 in 5 used it once a week. Daily use is more common among males than females. Probably doesn't surprise a lot of us. Most common among 18 to 29-year-olds. And most of those people will commonly use heads. That's the resinous flowering heads of the plant, so around 70%, and then leaf, another 35%. Recent users were more likely to use a joint, 84% of those, versus the bong or a pipe, 81%. And that's from 2008 data. Remembering again, 68.8% of recent users had mixed tobacco with their cannabis. So what are the risks and harms associated with cannabis use? If we look at just the short-term effects, they would include, obviously feelings of well-being, lack of coordination and concentration. That could be seen as a plus or a minus, depending on who you are. Clearly, if you were doing the previous presentation, you wanted them to drive, you wouldn't be looking for lack of coordination and concentration. Bloodshot eyes, loss of inhibitions, some anxiety and paranoia, sleepiness, and increased appetite and dryness of the mouth and throat. The earlier, and I think this is fairly significant, the earlier a person starts using cannabis and the more heavily they use it, the more likely they'll continue to use it and develop dependency and other related problems. So the longer we can delay initiation to cannabis smoking, the better it is, the better the outcomes are. The long-term effects can include increased risk of respiratory diseases, including cancer, obviously because it's a smokable substance, a combustible substance. Dependence is always a risk of any long-term use. Decreased memory and learning abilities, and decreased motivation, and that's what we often see, a combination of these factors. In terms of the respiratory effects, in the end, cannabis is primarily smoked, and smoke is smoke is smoke. It doesn't really matter. I know a lot of people feel that somehow cannabis smoke is different, but it isn't. It's very similar to tobacco smoke, and tobacco smoking is associated with emphysema, chronic obstructive pulmonary disease, respiratory infections, more of them, and more severe respiratory infections particularly, and obviously the risk of lung cancer. The evidence is strongest in terms of cannabis smokers and their negative health impact. The strongest is for an association with increase in cough, sputum production, airway inflammation, and wheeze. And certainly, anecdotally, cannabis smokers often report that they have a wheeze, not related to their cold. There isn't hasn't been shown to be a consistent association between long-term cannabis smoking and measures of airway responses like forced expired volume ratios and other such things. But when you look at the methodology, there were some problems with some of the 34 reviewed articles. So, I think that if there was more research, we would find that there was a consistent association between cannabis smoking and measures of airway response. And then, of course, it brings up, were they just smoking cannabis? Was there tobacco smoke in there? And the take-home message here is that the harmful effects of cannabis and tobacco appear to be additive. And I do recommend that you have a look at the NCPIC research brief number 6, which is the respiratory facts sheet, and it's an excellent bit of piece of information that Peter Gates has put together. So some of the problems that might be associated with adolescent cannabis use are the very factors that predispose young people to use cannabis often overlap with the other social factors and predict higher risk of use. So we might have things like social and environmental factors, particular adverse life events, family dysfunction, behavioural and emotional problems in childhood, and young people who use cannabis in early adolescence rather than that later initiation are at greater risk of experiencing mental health problems, having deviant peer affiliations and displaying antisocial behaviour, using other drugs, doing poorly at school and attempting suicide than the young people who don't use cannabis. So we can see that there are indeed problems associated with that. And then there's a complex relationship with mental health. I'm going to talk about, in a minute, I'll also talk about some of the problems with tobacco smoke, but the evidence increasingly suggests that regular cannabis use, particularly among those who begin using at an early age, say before 15, adds to the risk of mental health problems in adolescence. So there are 6 times more the risk of developing schizophrenia. That would, of course, be triggering something that was underlying, not causal. Cannabis use before the age of 15 predicts at age 16 school dropout and frequent truanting. So, it's a cause for concern. Some of the short-term effects that we know of smoking tobacco, yellow teeth and fingers, so some of these seem more cosmetic, but can be, in the end, long-term health problems. A chronic cough, reduction in taste and smell, weaker immune system, high chances of getting regular colds and flu, reduced potency in men, reduced fertility in women, negative effects on pregnant women and their baby, and smoking, of course, also affects skin to make the skin look older. Sometimes these more cosmetic symptoms are what we use to try and engage with younger people, because they're not worried about dying at 55 of a cancer-related illness or getting emphysema. They're worried about their skin looking wrinkly. So sometimes it's important to know these other effects. In the longer term, there's pretty much nothing that smoking doesn't affect. Cancers, particularly the oral cancers, lung and mouth and throat, lung disease, heart disease, cardiovascular diseases, increased risk of heart attack, stroke, circulatory problems, ulcers. Look, I won't continue to read all those because, really you could do a Google search and be there all day just reading long-term effects of smoking tobacco. And I guess I'll just go straight down to the bottom line here. Everywhere the blood flows, the toxins in smoke also flow and do damage. And I often find people want to sort of get out of jail free card for, but the bladder cancer wouldn't be related to the smoke, would it? And really, there is nothing I can say except everywhere the blood flows, the toxins in smoke do damage. So we know that cannabis and tobacco mixing is a common practice in Australia. People put it in their joints, their bongs, their pipes, and in the end it's smoke that does damage to your health. Whether it's cannabis or tobacco, it doesn't really matter, because both contain carbon monoxide and tars, particularly the polycyclic aromatic hydrocarbons that are a result of any combustion. So, in the end, it really doesn't matter if people, and there seems to be a hierarchy of sort of health where cannabis smokers somehow feel that they're not doing as much damage as tobacco smokers, and this just isn't borne out by the evidence. So why do cannabis smokers mull up with tobacco? Well, you know, it can make it go further when people are sharing. It is reported at times to have a synergistic effect for intoxication, so some people feel that they get more stoned. We also know that nicotine has an antitussive effect, which means it actually dampens the respiratory mechanism. So when you smoke it, not as a nicotine patch or any of the other oral replacement therapies, but nicotine smoked, it has this antitussive effect. And cannabis smokers don't cough as much when they smoke their joint or cone, and they know this. They just know that, you know, it's rougher when they only smoke it with just the cannabis. It is very much a cultural habit in Australia. It's very socially acceptable to mix, you know, with tobacco. Sometimes people say, well, what if I use some other herbal mulling preparation? You know, in the 70s, people used to use coltsfoot, which is a respiratory herb. And it really, again, it doesn't matter what you mix with, because they're still, once you light it, it contains carbon monoxide and the polycyclic aromatic hydrocarbons. And that's the things that we find in tar. That's really the ingredient in tar that's a problem for health. You know, mulling with tobacco, is there a reverse gateway? I mean, for many, many years, and I've been around in drug and alcohol for 30 years, and we certainly were hearing, when I first came into drug and alcohol, it's a gateway drug, it leads to hard drugs like, you know, heroin and benzos and all sorts of things. But really, when we look at it now, it's much more likely that cannabis is the gateway drug to a lifelong dependence on nicotine. So people initiate to tobacco and to nicotine when they smoke it in a joint, perhaps not or bong, not their own choice, but it's passed to them. It then becomes pivotal to the smoking of their cannabis. You know, for whatever reason, that's then increasing their dependence on nicotine. You know, and it may be that then as they mature and grow out of using cannabis, unfortunately, they're all already addicted to, you know, neuroadapted to nicotine. You know, and then there's the question of, is tobacco perhaps a gateway to cannabis? Because we certainly know that cannabis use is more common among tobacco smokers than in abstainers. So that makes us wonder about that. Some of the effects of co-use are that people who mix tobacco and cannabis experience worse outcomes than cannabis-only users. So, and that would be in regard to psychosocial health, cannabis use disorders, and continued cannabis use. Compared to cannabis-only users, co-occurring cannabis and tobacco users are more likely to report cannabis use disorders and higher levels of psychosocial problems. These include bipolar disorder, anxiety disorders, and antisocial behaviours. We have to look at the topography of smoking. That means actually how people smoke. So we already know that tobacco smokers are very good at titrating the nicotine dose, so that if you give them a lower milligram nicotine cigarette, which the tobacco industry were very good at marketing, they will naturally and biologically even out the nicotine that they need by inhaling deeper, right into the deeper part of the lungs, puffing more frequently, and smoking it right down to the butt, which is actually more hazardous smoking. So we don't, in the tobacco field, we've really tried to steer people away from this idea that they could be smoking healthier cigarettes that would have lower nicotine or tar. This is a furphy put about by the tobacco industry, and we call this kind of smoking Olympic smoking, deeper, more, right down to the butt. Cannabis smokers believe that they've got to smoke like this, and added to that, even holding the smoke in their lungs for a lot longer than they would a normal cigarette inhalation. And this results in approximately 5 times the uptake of carbon monoxide replacing oxygen in the red blood cells. That's what we call carboxyhemoglobin. So remembering that it's the oxygen in red blood cells, it's the red blood cells that transport oxygen around the body. So if you're replacing that oxygen with carbon monoxide, the red blood cells try to replicate to get more oxygen going, and in so doing make kind of what they call sticky blood, which is then a cardiovascular problem. So you're going to get 5 times carboxyhemoglobin by smoking cannabis in this very deep inhalation and holding it on. 3 times more tar inhaled and 1/3 more tar retained in the respiratory tract. And the thing is that there's actually no evidence that this causes a greater THC uptake. So I think there was quite a famous Dutch study that showed that 95% of the THC uptake happened in a normal, what you would call a normal cigarette inhalation. And remember, a joint is the equivalent of 3 cones and equals 5 cigarettes. So when people are trying to do harm reduction, they're actually probably increasing the harm, not the other way around. Bongs and water pipes, there seems to be this myth that somehow it filters out the bad stuff, and this just isn't the case. There's been a lot of work done on Arabic water pipe, smoking, the nargila or shisha in the Arabic communities. And we know that the nicotine is actually slightly reduced there, which makes people pull harder. And we think that this possibly will happen if it turns out that THC is perhaps less available through the bong. Smokers might titrate that dose even more by holding the smoke in the lungs longer, pulling on it harder. And they're more likely to have mold-related fungal respiratory infections that are very hard to treat because, again, it's coming through water. That's exacerbated by smoking cannabis and illegal tobacco, the chop tobacco we call it, that's been sprayed with water to increase weight. So unscrupulous dealers want to, be able to sell you something that's slightly less than the weight indicated, so they spray it with water. People then think, oh, I can, that's a bit damp, I'll put it in the oven or the microwave and dry it out. And unfortunately, a lot of these molds are thermoliable, so they're actually increased by the heat. And there's also, of course, the problem when sharing bongs and water pipes, that there's a risk of cross-infection with things like Hep A and tuberculosis. In terms of mental health, so we already know that cannabis has a significant impact on people that might be predisposed to mental health issues and psychosis. But there's also strong relationships with cigarette smoking. So cigarette smoking and cannabis users cannabis use are equally strongly associated with what they call PLEs, psychotic-like experiences. And there is a dose-response relationship between the smoking of cigarettes in adolescence and then later psychotic symptoms in the general population. We don't know. There seems to be a synergistic effect, but we know that by itself, tobacco smoke can be harmful to mental health. So using them both together, is it additive? Is it synergistic? We just don't know. The PAHs that I referred to in all smoke, and they're a product really of just combustion of organic compounds. So you don't get away with it, just because you're not smoking tobacco. It still means you're getting the PAHs. And those PAHs interfere with the pharmacokinetics, the metabolism of other medications, particularly clozapine, olanzapine, and other meds such as antihypertensives and substances like caffeine. So we know that smokers usually are on much higher doses than non-smokers of many medications. And so they would need a responsible prescriber to reduce those medications when they've stopped smoking or significantly cut down. And then if relapse occurs, they also might need to increase those meds. We don't want people either over-medicated or under-medicated, really. When we look at nicotine withdrawal, we can see, obviously there are cravings for tobacco. There's, on the left-hand side, you'll see the sort of mood effects of withdrawal, and on the right-hand side, more of the physical side, including things like insomnia. But obviously, cravings are the biggest symptom that people experience. Remembering that those first, 1 to 2 days are the most intense time of a nicotine withdrawal. And looking at the cannabis withdrawal, which starts 18 to 20 hours, I would posit the theory that most people, when they say they're withdrawing from cannabis in that first part of the day, are actually withdrawing from nicotine at the same time. So, we say that the symptoms of nicotine withdrawal start abating after about 2 weeks. That's for nicotine, but for cannabis it's a sort of 1 to 10 days withdrawal. You can see again that there's the sort of the mood disorders that you can experience with cannabis withdrawal and sleep difficulty. So a lot of these symptoms are overlapping, and so it is quite confounding when you're trying to do research on this. So the treatment issues, really we've had very different public health messages around cannabis and tobacco, and because tobacco is illegal, it is a legal product, it's been a lot easier to get those public health messages out. Cannabis and tobacco are perceived really differently by smokers, by users, in relation to the sort of concepts like, addiction, dependence, harm, reasons for quitting. And, there may be that people are just not educated around the relationship with cannabis and tobacco. Cannabis smokers wanting to quit tobacco report smoking more cannabis. Tobacco smokers who want to stop cannabis report smoking more tobacco. So, it gets very tricky there. And obviously there's a higher rate of relapse if people are trying to give up one without the other. That's often the case. So if you're assessing people, AOD workers and tobacco workers often ask questions like, do you smoke or are you a smoker? If the person doesn't smoke cigarettes, they often answer no, because they don't feel they're a cigarette smoker, but they may be smoking 20, joints or cones a day, but they would still say they're not a smoker. So I've changed the way I ask questions now. I actually ask people, do you smoke anything? Because by asking that, they actually realise that you understand there might be something other than tobacco. But you may then have to persist and specifically ask if they smoke cannabis. Tobacco smokers who also smoke cannabis will often say they want to give up the cigarettes but not the cannabis. So I would then ask, when you smoke a joint or a cone, do you usually smoke a cigarette straight after? Because most of them will. The cue is very strong. So they'll have pull a cone and then they'll light up a cigarette anyway. And then I'll actually just bat that question back. So how do you think that's going to work? And really, it comes down to trying to get them engaged in the process. I always suggest that the best option is to quit smoking anything for a while because of that cue extinguishment. If you're still smoking a joint and you're trying to give up tobacco or vice versa, it's very hard to see how that's going to work. And it's often linked with other drug use and alcohol anyway. So sometimes people find it's easier if they go into a detox or rehab to just stop smoking because it stops the cues back to a lot of other alcohol and illicit drugs. Cannabis smokers who mull up with tobacco but don't smoke cigarettes, it's likely that they're actually smoking more cannabis than they need to get stoned. So I would then ask, do you smoke another joint to get more stoned or just to smoke? And for me, that's just the beginning of their self-reflection process. It's possible that you could get people to put, and this is just stuff that's sort of we're all talking about at the moment and no one's really tried this much, but occasionally I've got people in my quit smoking groups to put an NRT patch on around their cannabis use as well and seeing what happens. Because if you put a nicotine patch on, there will be a baseline of nicotine coming and that you won't be pulling as hard on the joint or bong. They might find that they're smoking less cannabis and they're not craving nicotine. And NRT helps to down-regulate the nicotine receptors. So they'll actually reduce the amount of receptors and reduce the withdrawal symptoms and really help the whole process. So we know that eventually the brain does get back to normal if there hasn't been too much time of smoking. Sometimes when people have smoked for too long, there's just no way that there's going to be down-regulation. Some smokers decide to eat cannabis as a cake or biscuits or drink it as a tea as a harm reduction strategy, but will complain that, they don't want to be that stoned. It's a longer onset and a longer drug effect. But it might be an option for people if they really want to quit smoking, as it does remove those kind of smoking cues. Is simultaneous cessation the answer? Are people really going to want to give up both? In my experience, they often don't, and we have to really start that conversation with them. There was a study by Becker saying that the group cessation program, based on the usual motivational interviewing CBT, worked very well in a 6-course session. is vaporising going to be an alternative? We don't know, but it is at least a non-combustible route of administration. It may be better than smoking. The problem I can see is that if it's minimum $100, $150 for a vaporiser, and a lot of my disadvantaged smokers, I know that they would just look at that price and go, but I could buy some more pot. You know, why would I buy something that I could spend on my weed? So, and unfortunately, there are a lack of long-term studies on the health effects of that. Just to finish up, the sort of workers' issues, there are ethical dilemmas for some workers to discuss cannabis use with tobacco smokers, and they don't want to be seen to promote cannabis use by offering strategies for smoking cannabis without tobacco, or ingesting, or rolling their own joints and not sharing. And then the problem I see with AOD workers is they often don't see tobacco as a real drug, so that, hence a lot of the detoxes and rehabs you can still smoke in designated areas. And then the 12-step programs like NA don't even see cannabis as a real drug. So there's a whole lot of dilemmas because we're kind of working in different silos, and I think, you know, there's a lot of advantage in combining the two together. Thanks very much, and I do just want to thank Eddie Matalon and Maddie Randell from NCPIC for their fine slides that I poached.